Live from Boston, my name is Emilio Madrigal. Today is Tuesday, July 13, 2021, and welcome to this edition of Pathcast. Today, we're very happy to have Dr. Eve Crane from the Cleveland Clinic, and she's going to be presenting a HemePath lecture titled Approach to Small B-Cell Lymphomas, Pearls, Pitfalls, and Prognostic Factors. As always, Rafad and I will be on the monitoring the broadcast, and if you have any questions or comments for Dr. Eve Crane, you can post them in the Facebook and YouTube chat windows, and we'll make sure to pass those along to Dr. Crane at the end of the session. So with that, I'll turn the microphone over to Dr. Crane.
Oh, thank you so much. I'm thrilled to be back on Pathcast. This is my second edition. The first one we looked at approach to the lymph node in general. This time focusing in on small B-cell lymphomas. The approach and many of the examples are adapted from our recent text, which is just out, written together with Dennis O'Malley through Innovative Science Press. And I encourage anyone to take a look at those. They have a whole series which are really written by some fantastic authors. But anyway, so today we're focusing in on these small B-cell lymphomas, which I think are some of the real bread and butter of hematopathology, and kind of an exciting area because we can really use all of our skills. You know, we rely on morphology. We're looking at we use flow cytometry routinely. A lot of ancillary testing is extremely informative for treatment and prognosis. So it's one of the areas where we collaborate closely with clinicians and I think really have an impact for patients. So today the objectives are going to be to differentiate small B-cell lymphomas from reactive proliferations as well as from low-grade neoplasia that is of unclear clinical significance. Next, if we have a bona fide small B-cell lymphoma, how can we subclassify that based on morphology, immunophenotype, and available markers? And as I mentioned, this is an area where biomarkers really come into play because most of these disorders are relatively indolent. Patients may live with these disorders for a long period of time, and we really need to find out who needs more aggressive therapy or when therapy should potentially be initiated. So it's a very, a more important area for biomarkers than others even within hematopathology. And of course, we're on the lookout for other signs of unusual features or transformation. So we begin similar to as you would to any lymph node with a compartment approach, potentially even looking at very low power, even at just the slide itself. Does this lymph node look normal? Is it enlarged? Is the capsule thickened or fibrotic? Beginning at low power, are the sinuses patent? Is there an increase or atypical proliferation of vasculature? And what is the relationship of the paracortex and the follicles? So are we seeing kind of a normal distribution? In this particular lymph node, we're seeing kind of a markedly expanded paracortex with only kind of these small interspersed follicles here. Just kind of, we can see that there's definitely a disruption of the architecture here. And that is a sign that we need to delve further. Is this a lymphoma? And of course, obviously looking for any sign of metastatic disease, which could coexist potentially with a low-grade lymphoma. So we have multiple patterns that we can see, as I alluded to. You could have predominantly small lymphocytes or kind of a diffuse expansion. You would see that particularly in the setting of like chronic lymphocytic leukemia or small lymphocytic lymphoma or lymphoplasmacytic lymphoma, or classically your predominantly follicular distribution that's an increase in atypical follicles with a lower degree of a paracortex. That's a classic example of follicular lymphoma. Or kind of a mix, as we saw in the first example I showed you. You have some follicles, maybe some follicles in diffuse areas, interfollicular expansions of lymphoid cells. These are maybe the most common thing that you'd see, and you can see that with a marginal zone, with variable involvement by mantle cell, and also depending how the CLL, SLL may distribute in the node. So you could see that in a variety of small B-cell lymphomas. Mixed small cells and large cells. You may see that, I mean, obviously that's a hint. You want to also rule out that you've got like a Hodgkin lymphoma or something else going on, but it could be seen in marginal zone lymphoma, which can show increased large cells, which may not necessarily be of significance, but can create a heterogeneous and atypical look. Follicular lymphoma, such as grade 3A, where you have a mixture of centrocytes and centroblasts, lymphoplasmacytic lymphoma, or increased proliferation centers in CLL, SLL. So site considerations, the lymph node is obviously what we most commonly think of, and the widest array of small B-cell lymphomas, after all, that's kind of where they're localized, where normal lymphocytes are localized, will be seen in the lymph node. So like CLL, marginal zone, lymphoplasmacytic lymphoma, mantle cells, follicular, very rarely B prolymphocytic will be in the lymph nodes, but also extranodal sites are a lot of the specimens that we get. And these, you may not have flow cytometry, you may not have other ancillary tests available for these extranodal sites. But of course, marginal zone lymphomas, mucosa-associated lymphoid tissue, and MALT-associated lymphomas are seen in the stomach, breast, lung, lacrimal gland, in the meningeal dura, salivary gland, which I've shown here at right. So those are very common sites that we may see sampled, and there you have kind of the challenges of differentiating a reactive lymphoid proliferation from, is this really a lymphoma? Other sites of the GI are also commonly involved. Follicular lymphoma is not uncommon. We have a new kind of special designation for follicular lymphoma that's isolated to the duodenum, that's very indolent. But mantle cell also likes the GI tract quite a lot, and of course marginal zone in the stomach, but also in other sites. In the skin, of course, the T-cell lymphomas maybe get a little bit more attention, but we do have a number of small B-cell lymphomas that may involve the skin, including cutaneous marginal zone, primary follicle center cell, which should be distinguished from systemic involvement of follicular lymphoma, and generally can be. And the bone marrow is another site where you can pretty much see a huge array of different small B-cell lymphomas, but in particular, as compared to lymph nodes, we're seeing hairy cell leukemia variant, lymphoplasmacytic lymphoma maybe more commonly, and all the other ones can be in there as well. Follicular lymphoma, of course, has that very characteristic paratrabecular pattern when it involves the bone marrow. The spleen is also kind of a special and very interesting site. We have a special splenic form of marginal zone. All of these ones that involve the bone marrow also typically involve the spleen, such as hairy cell variant, and splenic diffuse red pulp will generally involve both spleen and bone marrow, but has a very characteristic pattern involving the red pulp as compared to splenic marginal zone, which enables them to be differentiated. But CLL, lymphocytic leukemia, all these things also go into the spleen. All right, so the workup. What should we do? So first we look morphologically. We've got a specimen with kind of an abnormal lymphoid proliferation. This is a colon that clearly shows, something that doesn't quite look reactive. It's kind of monotonous looking proliferation of small lymphoid cells here. And because it was a colon polyp, it wasn't sent for flow cytometry. So we have a IHC workup that we typically do. We have a small B-cell immunohistochemical panel, which includes about 10 to 12 stains. But at the most basic, especially if you don't have flow, it's nice to look at the distribution of T cells and B cells. Like what is, basically what is going on here? Because you could have an indolent T cell proliferation in the GI tract as well. So we like to compare CD3 and CD20, and as well CD5. Does that correspond with the CD3, or is it aberrant? And this was a particularly nice example where we're seeing relatively limited amount of T cells by CD3 and kind of diffuse dim positivity by CD5, and then strong staining diffusely by CD20. And indeed, this ended up being mantle cell lymphoma involving a colon polyp. The next, in that particular example, we didn't have a whole lot of follicles to worry about, but often you do, and you're like, well, are these normal follicles? Are they reactive follicles? Or are these actually atypical? And here in this case, we see the follicles are a little bit spaced out. They're not quite back to back, but they don't look quite right. So it's nice to employ our panel of kind of germinal center markers. They should be positive for CD10, BCL6, and be well polarized by Ka67. And we do see that they have 10. It's kind of a little bit stronger than typical, strongly positive for BCL6, but very low Ki67 proliferation rate. So you know it's like these are not normal follicles, and then they've got aberrant expression of BCL2. And so follicular lymphoma is kind of nice because if you do see that co-expression of BCL2 and BCL6, you know you're dealing with a neoplastic process, also part of the panel. And just another word on Ki67, I feel like even if I do, even just like a slight screen of a lymph node, I think may look a little bit atypical. If I see a normal Ki67 pattern, I can kind of breathe a sigh of relief. But if I don't, it can give me a lot of information. For example, here's, in follicular lymphoma, seeing this lower proliferation rate, non-polarized versus the nodal marginal zone, where I've got these retained kind of high proliferative polarized follicles that are partially disrupted by kind of these small lymphoid cells here, small B cells. And so that's extremely helpful. And there's a number of other patterns that you can see. So Ki67, I think even though it's maybe not prognostic in many small B-cell lymphomas, it is very helpful in terms of the differential diagnosis. And of course, if you have something that's more aggressive, this is a pleomorphic mantle. In the bone marrow, you see diffuse positivity for Ki67, very concerning, and this has had a very aggressive course, which you probably also would have anticipated from the morphology, but certainly confirmed with the Ki. And then this is one that I know I've talked with some of my hemopath colleagues. One of the things that we find the most useful in terms of our staining armamentarium are looking at dendritic meshworks. And, we want to look, are they expanded? Are they disrupted? Are they absent? And these are things looking for transformation or even just looking for patterns of a small B cell. This is kind of a nice example of follicular lymphoma with CD21, where we're seeing this kind of expanded follicular networks that are associated with the atypical follicles. Expanded networks can also alert you to potential concern for background T-cell lymphoma, such as angioimmunoblastic or other things. And disruption of dendritic meshworks in the setting of marginal zone. In this case, they're still relatively intact. You can see they're partially disrupted by this small B-cell infiltrate. The same cases we saw with the Ki above. Of course, looking for plasma cells and clonal plasma cell proliferations is also potentially helpful, particularly when you're thinking about a lymphoplasmacytic lymphoma or a marginal zone lymphoma. You don't always win. Sometimes the plasma cells are polytypic and it's still a marginal zone lymphoma. But if you do see an associated clonal plasma cell population, that's helpful. And of course, we have a lot of secondary plasma cell stains that can be used as well. And it's also helpful in these B-cell lymphomas that have extensive plasmacytic differentiation to kind of think about CD79A. Sometimes CD20 may only get a minor subset of the B cells, and you don't realize that you really have that expanded of a B-cell population until you look at kind of markers that show maybe broader expression in post-germinal center B cells such as CD79A. Okay, so we also have a whole bunch of markers that are kind of increasing in utility that are useful for subtyping different forms of B-cell lymphoma. And of course, the classic one, and I don't think anyone's ever going to fault you for, like doing a cyclin D1 stain on a lymph node. Make sure you don't have a mantle cell lymphoma. That's not normally expressed in lymphoid cells, in the majority of lymphoid cells, and so that's very helpful. And if you're differentiating on a piece of tissue between a CD5 positive mantle or could it be CLL, it's very helpful if you see that cyclin D1, you're dealing with a mantle cell lymphoma. And SOX11 is also helpful, can be used in ones that don't have the cyclin D1 translocation, but instead have cyclin D2. CLL, SLL also typically will show CD200. You can do that by flow or by IHC or LEF1. It's a transcription factor that's normally in T cells, but it's not normally in B cells, so that can be helpful. Now, hairy cell has a whole pile of things that we can look at by flow and by IHC. So usually you can nail down a hairy cell leukemia diagnosis pretty well. Marginal zone can be a troublemaker because you do have reactive follicles, and potentially in some cases you can have overlapping features between marginal zone and follicular lymphoma. And so we have a number of markers for those settings, looking at myeloid nuclear differentiation antigen. This is actually in the skin. These nodules involving lymphatics were nicely labeled because you didn't have necessarily the typical pattern, were nicely labeled by MNDA. And IRTA1 is one that we've recently brought into our lab, which is really helpful. In terms of germinal center markers, obviously CD10 and BCL6. Secondary ones like LMO2, GSET, and MEF2B are used. We recently started using MEF2B here at Cleveland Clinic, and it's really beautiful, very clean stain. So I recommend that one if you want to bring on another potential germinal center marker. And of course, because these lymphomas tend to be fairly indolent, the patients may have received multiple therapies in the past. Often they've received an anti-CD20 therapy, such as rituximab, and the cells may no longer express CD20. So looking in the tissues, sometimes it's helpful up front to do additional B cell stains, particular PAX5, which is a nice nuclear stain, or CD79A, which will get kind of more post-germinal center cells, as I mentioned, particularly like CD79A for CLL that's been treated to verify involvement. And of course, additional markers can be targeted, and so oftentimes the clinicians will want you to look at those, like 19 or CD22, usually a little bit better by flow, but they can also be looked at in tissue if you have those antibodies on hand. I didn't mention too much on flow yet, but flow is really your friend for these small B-cell lymphomas. These cells typically dissociate well. They'll live really well in suspension. Like even a week later, you're like, you know what? I should have run flow. You could still run it because usually they're just hanging out there, and you can get a very nice phenotype on them, particularly if you have partial involvement or you have mixed populations of cells, like in a marginal zone. Extremely helpful to get that flow phenotype. And sometimes you may have, CLL, that's in the background, or some sort of monoclonal B-cell lymphocytosis in the background that's different from your main population of small B-cell lymphoma that you're dealing with. And so you can really tease out all kinds of intricacies if you've got the flow. And of course, classically, this is a hairy cell leukemia case involving the bone marrow. It shows very characteristic findings and co-expression of certain markers that can enable you to really nail that diagnosis if you've got that distinct pattern with the very bright expression and CD25, CD11C, and CD123 on those cells. So that's extremely helpful in those instances. Let's see if this thing else. Okay. Of course, in many instances, you don't have flow. Like I mentioned, like you maybe, this is a colon polyp, or, it's a resection that was done for conservative metastatic carcinoma, so they didn't want to utilize some of the tissue for flow. So we have a number of ways to get around that. One is if you're kind of considering, well, this is probably CLL or, splenic marginal zone or something, you can look for what is the pattern in the peripheral blood. Do we have maybe, if we can show that we've got leukemic involvement by that lymphoma in the blood, that may be helpful diagnostically and help us really nail down. These are also really helpful. This is something we frequently use in the setting of like malt lymphomas, particularly gastric malt, because you may get multiple repeat biopsies or even more difficult to interpret. So if you have that clone that you're looking for, you can determine more easily if there's residual disease. But we also have a new technique, which is kind of cool, and we're still gaining experience with here at Cleveland Clinic, which is using an ultra-sensitive form of in situ hybridization for kappa and lambda. And so typically the kappa and lambda will, the IHC stains will really only get the plasma cells that have the cytoplasmic light chain in it, and often the IHC, the regular, and also the plasma cells. But this one allows us to detect the RNA in both B cells as well as follicles, showing when it looks really clean. Now these follicles look kind of monotonous and atypical. It's an example of follicular lymphoma, and we're seeing lambda restriction in all these kind of small B cell nodules with only scattered brown kappa cells. When you'd like to use it is potentially in the setting of a marginal zone lymphoma. This is actually a marginal zone lymphoma involving the thymus, where we have some residual polytypic areas, as you would expect. You'd expect to have some polytypic germinal centers left, and there is, there are plasma cells that are polytypic in the background, but there is quite a bit. You can see these areas of maybe perifollicular proliferation of small B cells that are kappa restricted, clonal B cell population by molecular studies as well. And this this is a reactive lymph node where you're seeing kind of a robust plasma cell proliferation, but they are polytypic and polytypic B cells. So that can be very helpful because you then, you don't just have the clone, you can actually see how those clonal cells are distributed within the tissue. So I think it's useful. Okay, so now delving into some of the small B-cell lymphoma subtypes. We've got our specimen here. We know it's probably got lymphoma. That one looks like some fish flesh going on there. So how do we really characterize these different lymphoma subtypes such that it's useful to our clinical team? So one of the most common forms of lymphoma, one of the classic ones that we see, and very useful across pathology because these cells will pretty much involve any tissue or any other tumor when they can and when they're around. And we call it, basically chronic lymphocytic leukemia, small lymphocytic lymphoma, because we have these same cells that are either circulating or involving tissue. They're small lymphoid cells typically with round nuclei, clumped chromatin, and very scant cytoplasm in general. However, both circulating as well as in tissue, you'll see a subset of larger cells, often kind of with a pro-lymphocytic phenotype that have increased cytoplasm, prominent nuclei, and they may be like in kind of little proliferation centers in the lymph node, or they may be circulating. And certain treatments as well can increase the number of these that are circulating, kind of give you a little bit of a scare. But certainly at diagnosis, these need to be less than 55%, usually much less. If they're greater than 55%, then you're dealing with a more likely a pro-lymphocytic leukemia or something else. But a ton of biomarkers have been developed in this setting. For one thing, we have a very characteristic phenotype that we can identify. And, oftentimes you can do that by flow cytometry. They've got CD5 in general, very dim 20. They'll co-express CD23, CD43. CD200 is emerging as a fairly robust marker that a lot of folks are including on their flow panels now, but it can also be looked at in tissue, which is helpful. They'll express the LEF1 transcription factor, as I've shown here. Now that will overlap with the T cells, but as you can see here, we got way more 20 than 3. So we can be assured that that LEF1 is in the B cells there. But yeah, actually a lot of people have these random clones, and with our flow cytometry being so nice with a specific phenotype, that we can just find these clones in people that may otherwise really be asymptomatic of developing significant repercussions from these cells. So we have a category called monoclonal B-cell lymphocytosis. Your normal white count is, be a decent number of your white blood cell count, but if it's not increased above 5 times 10 to the 9, then you have a very low risk of progression, as long as there's not other sites of involvement, like that it's not, the nodes are not enlarged and there's not significant extramedullary disease. There can be some disease in the bone. A set of people who have this very low level involvement, 0.5 times 10 to the 9, and those folks have an extremely low level of progression. And of course, it's important to note that these cells are negative for such to rule out a possible mantle cell. However, these proliferation centers may show very dim cyclin D1 expression because they are proliferating, but that is usually not to the level where you'd even think about a mantle. So there's a number of clinical markers that have been developed. They're measured clinically, they're measured morphologically, and they're measured genetically. The clinical markers are often tied into this Ryan-Benet staging system: anemia, thrombocytopenia. Patient may have a hepatosplenomegaly. Beta-2 microglobulin levels correlate with the CLL, SLL mass. But from our standpoint as pathologists, we're looking for increased proliferation centers, increased prolymphocytes. Sometimes the cells have a little bit of an atypical morphology, for example, in trisomy 12, and that's associated with a little bit more aggressive phenotype as well. Other markers kind of vary in terms of which ones are favored at individual institutions in terms of directing therapy. But this is kind of a semi-comprehensive table of them here. As I mentioned, trisomy 12, associated with slightly worse prognosis. Anything that's happening to TP53, deletion, mutation, these patients may not respond as well to standard therapy, so it can be worthwhile to assess that up front. So-called mutated versus unmutated status. Of course, B cells undergo somatic hypermutation as they get more refined towards a specific antigen. So those B cells that are derived from more somatic hypermutated cells, the mutated with less than 98% identity to germline, are associated with a better prognosis than those that are unmutated. And these unmutated status also correlates with other negative markers such as ZAP70 expression, which is measured in many institutions by flow, CD38 expression, alpha-4 integrin expression, or a naive epigenetic subtype, also certain mutations. And this area continues to evolve because some of them are more or less relevant as treatments are advancing as well. This is an area where we are in constant contact with our clinicians to make sure that we're providing the right molecular data as these new cases are diagnosed that is informative for what they want to do. Now, as I mentioned, a subset of cases may show more atypical morphology. And, if you see something that really looks kind of crazy like this with these big cells with increased cytoplasm and prominent nucleoli, and this is the majority of the cells, it brings to question, could this be a B prolymphocytic leukemia? Of course, in that case, you always want to rule out that it's not, circulating atypical mantle cell lymphoma or something like that. But these patients will typically present with a very rapidly rising white count, generally greater than 100. Lymph node involvement is less common. However, we did have a case here where we were able to get a nice touch preparation of such cells involving a lymph node. But there's no real specific marker for it. It's more in the clinical presentation, and it can certainly show overlapping markers, marker expression with CLL. So it's important not to, or mantle cell, so to not misdiagnose when you could have specific markers for those. Okay, so moving on to mantle cell lymphoma, this is really kind of a nice classic picture where you kind of see these small to medium lymphoid cells, mature lymphoid cells typically with kind of, clumped chromatin and angulated nuclei. It's relatively common, around 3 to 10% of non-Hodgkin lymphomas is something you encounter with some frequency in diagnosis. Most of the patients, and that was kind of a typical biopsy that you might see, and most of the typical patients would present at advanced stage with these cells involving multiple sites, such as the spleen and liver, lymph nodes, bone marrow, often circulating in the blood as well. And of course, they will characteristically have this T1114 translocation of IgH and cyclin D1, resulting in the overexpression of cyclin D1, which is really helpful from a diagnostic standpoint. They also will co-express CD5 in most cases. A subset will show CD10 or even both, and they could be negative for CD5, so you can't exclude it. And SOX11 is a really helpful marker for detecting cases that may alternatively contain the cyclin D2. However, it's also important because you can also detect these cells and they end up being kind of an indolent leukemic non-nodal form of mantle cell lymphoma, and those tend to be negative for SOX11, and so SOX11 can also be used to differentiate between these forms. However, the leukemic form, once it acquires like a p53 mutation, can also be aggressive. In addition, any other mantle cell lymphoma that acquires the TP53 mutation is also considered prognostic, as well as kind of these more atypical morphologic appearances of a pleomorphic or blastoid variant. And in most small B-cell lymphomas, like I said, I like to measure Ki-67, and it gives me an idea of the pattern and kind of the overall architecture of the tissue, but we usually don't use it from a prognostic standpoint. But in mantle cell, we do. It's one of the ones where we do report out a Ki-67 proliferation rate associated with a more aggressive course. But as I said, the typical presentation of mantle cell lymphoma, you may have kind of diffuse involvement, kind of medium-sized cells, but you can have a huge range. Like as you mentioned, you have this indolent circulating form. You can also have these completely incidental form in a node that otherwise looks normal, which we now call in situ mantle cell neoplasia, which you will still have that 1114 translocation, the cyclin D1 expression. We're probably not going to see it unless you happen to stain this lymph node for cyclin D1. And so that's called neoplasia because it's not a true lymphoma. Of course, then we range all the way. This is the H&E section of the pleomorphic mantle cell lymphoma I showed you earlier, to this, which is just diffusely replacing the bone marrow, 100% Ki-67 proliferation rate, and a very fulminant course. And some other examples of involving different sites: lymph node, bone marrow, and of course, in our patient that we saw earlier with multiple colon polyps. Here we see the cyclin D1 and those cells which had the dim CD5 and diffuse CD20. And so these colon polyps are involved by lymphoma. They have this name, lymphomatous polyposis, which can actually be, but mantle cell lymphoma is the most common one to do that. And not to be confused with lymphomatoid papulosis, which is CD30 positive, typically CD30 positive proliferations of the skin. Lymphomatous polyposis are these basically lymphoma involvement of colon polyps. So this is a little kind of the range that we see from classic to more aggressive blastoid or pleomorphic variants to the leukemic non-nodal, which is important to recognize because they often kind of watch and wait with these guys, and they show overlapping features in some cases with CLL, including expression of CD200, creating some potential diagnostic challenges, and in situ mantle cell neoplasia, which should be distinguished as being more indolent and may or may not ever develop into a frank mantle cell lymphoma. So the next really classic small B-cell lymphoma is follicular lymphoma. This is actually the second most common nodal lymphoma, comprising around 40% of non-Hodgkin lymphomas. And this is a nice example over here where you see kind of these back-to-back tissue. They're relatively monotonous in size. We don't have well-developed mantle zones, and they're not polarized and facing a background tissue architecture. And so these are germinal center cells that have failed to undergo apoptosis in general due to expression of BCL2 protein, and in most cases that's a result of these IgH BCL2 translocation, the T1418 translocation, although that's less commonly seen in higher grade follicular lymphomas. And so as I mentioned, you have these proliferation of these, most typically you have these proliferation of these abnormal factors. Although, because it is so common, you can see a whole variety of variants of this, of not really any necessary clinical consequence, but kind of described like a floral variant. Occasional forms and tingible body macrophages can be seen in a subset, which definitely can create a confusion between a reactive or florid follicular hyperplasia, but these should not be polarized. In particular, you can see that in lymphoma. So follicular lymphoma grading is probably things in the field of hematopathology. Within a normal lymph node kind of germinal center, you'll have, but you'll get more of a kind of a monotonous and non-polarized mixture of these cell types in follicular lymphoma. In particular, in the low grade, you're going to see predominantly kind of angulated or round oval nuclei. And if you had a sheet of these, it would look like a diffuse large B-cell lymphoma, but they can be, just kind of intermixed. And they've got, they typically have one or more peripheral nuclei, and then a rim of cytoplasm. Now, both of these, can be intermixed. They're a little bit intermixed in the bottom case. And so if we want to grade this, we're looking for at least 10 follicles to review, and we need to have less than 15 centroblasts per high power field. And for grade 3, we're going to have more than 15, but in 3A, there's still some centrocytes present. In 3B, we've got sheets of centroblasts, yet it's still arranged in a follicular pattern. And so here's our typical immunohistochemical staining pattern for follicular lymphoma. We can see here, this is a nice example with some back-to-back follicles, fairly monotonous appearance by H&E. They've got a low proliferation rate, a non-polarized bright CD10 in this case, BCL6 is positive, and they're co-expressing BCL2 diffusely and in the same cell. So that's a nice example of just bread and butter follicular lymphoma. There's a variety of pitfalls, probably could go on in pitfalls, but certainly if you have diffuse areas comprised entirely of centroblasts or other diffuse areas that are clearly a higher grade cell, then you're going to have either focal transformation or complete transformation to diffuse large B-cell lymphoma. And staining for meshworks can also be helpful in that setting. And that can be listed as a separate diagnostic line if you've got focal areas of transformation. But what if you have like diffuse areas that are just centrocytes? They're not central blasts, and that's fine. That may coexist with a follicular pattern, or you may have the diffuse follicular variant, which is typically negative for the IgHBCL2 translocation. Rena Shen and colleagues at Hopkins recently published a nice paper on this, on some characteristic genetic findings as well as morphologic findings in these cases. They tend to, as I say, lack the characteristic BCL2 translocation, but they do have recurrent deletions of 1p36, often express CD23, and can be recognized as such. Another one that can cause some trouble is the blastoid variant, relatively rare, but the cells kind of resemble kind of more a lymphoblastic appearance. And these appear to be a little bit more aggressive. They have a high K67 proliferation rate, and certainly if you see something like this, to include a note regarding that fact. BCL2, that is more common, for example, in grade 3 disease. Others aren't really negative, but in addition to a translocation, the BCL2 has undergone additional mutation, and it'll actually mutate at the site where the antibody normally binds. And so they'll appear negative by one antibody clone, but then you can detect it by a different antibody clone. And this is a nice example of one shown here, where using the standard clone in our lab, the 1G4 clone, we have the follicles are largely negative. There's a subset of cells that show bright staining, almost looks like an in situ follicular neoplasia or something. But then when we stain with the EP36 clone, we see they're diffusely positive for BCL2. So in other words, that many of the cells may have undergone, then had a secondary mutation and lost that antigen binding site. But it's handy to have both clones to look at that. But again, with the morphology, you can usually arrive at that diagnosis, and you're not required to have expression of BCL2. Special subtypes, similar to mantle cell, we also have an in situ follicular neoplasia that's kind of an incidental finding. And by incidental, that means that if you looked morphologically at the node, you really wouldn't be able to see it. And so people say you missed it. You say, well, if you missed it, then that's not the diagnosis, because you can't see it. But if you stain, come up with these CD10 positive, really bright follicles that have a low Ki, and then have a high BCL2 expression, most typically very bright, typically. And these involvement by a systemic follicular lymphoma, because obviously the implications would be different. A subset of cases are associated elsewhere with follicular lymphoma, either concurrently or in a subsequent or prior biopsy. And they can also be associated with other types of lymphoma. For example, I've seen them, you're doing certain stains because you're looking at an angioimmunoblastic T cell lymphoma, and then you see this also in an area of uninvolved node. So the significance of this is not necessarily clear, but it doesn't necessarily relate to much of an increased risk of follicular lymphoma in and of itself. Special type, as I mentioned earlier, is the duodenal follicular lymphoma. This will show characteristic features and phenotype of follicular lymphoma with these, atypical follicles, positive for CD10, BCL2, BCL6. But as long as it's localized just to the duodenum, then it's very indolent. And it's often an incidental finding as part of GI scoping procedures to be identifying these nodules. Pediatric follicular lymphoma is a little bit of a different entity. It is typically BCL2 negative, typically lacks the IgH-BCL2 translocation, and is predominantly in children, predominantly males, often in the head and neck region. All these patients have a low clinical stage. The good prognosis, often just excision, is sufficient. And what you'll typically see are these expansile follicles with numerous tangible body macrophages, but they're not, and high Ki67 obviously going along with that, but they're not polarized. So that's a very distinctive entity, but fairly rare. Okay. Doing okay on time. I think there's small B-cell lymphomas are a big part of what we do in HemePath. So I try to tackle it all for this lecture, but we'll see. Marginal cell lymphomas are another major area. These are post-germinal center. They're usually negative for 5 and 10. We often don't have a specific marker, and they're kind of heterogeneous. They're composed of small lymphocytes. You got monocytoid B cells, which are kind of that rim of clear cytoplasm, and a variable number of plasma cells. You also can have some large transform cells interspersed to varying degrees that also can, in some ways, resemble even a reactive process, or is it maybe a more aggressive process? They have kind of a range of looks that can create challenges. In addition, you nearly always have reactive germinal centers present. This is a gastric malt. You can see here there's kind of expanded lymphoid proliferation around a reactive germinal center. And so we have three main subtypes that actually, cutaneous marginal zone could be a separate subtype as well, but extranodal marginal zone mucosa-associated lymphoid tissue or malt lymphomas, primary nodal marginal zones, and splenic marginal zones. Most of these are typically indolent. So in terms of malt, these are the most common. They represent 78% of all lymphomas, 50% of lymphomas you're going to encounter in the stomach. And around a third of cases will show a serum paraprotein, which can potentially be helpful in diagnosis or monitoring, typically IgM. In cutaneous cases, more often IgA or IgG. Some of these cases may relate to chronic antigen stimulation, and so hence why you might see reactive germinal centers there in kind of a spectrum as they progress from a more reactive to a more neoplastic looking process that they may be evolving over time. And in particular, we see them in relation to H. pylori infection, of course, in the stomach. Less well established are other bacteria in other sites. That is certainly likely. We also commonly see lymphoepithelial lesions. I didn't show that here, but the lymphocytes like to home to epithelial structures, so that's one characteristic finding of malt lymphomas, particularly you'll see. Overall, we don't have anything perfect. We don't have anything like cyclin D1 or co-expression of BCL2 and BCL6 to really nail the diagnosis, but oftentimes they will express CD43, and so that can be helpful when that's expressed in the B cells aberrantly. Nodal marginal zone is much less common than malt, and secondary nodal involvement by a malt lymphoma may be more common. So it's important to exclude that. Also, lymphoplasmacytic lymphoma can also create a challenge. Bone marrow involvement is more common in terms of a nodal marginal zone as compared to a malt lymphoma. And we see kind of a little bit less of the monocytoid just around reactive follicles. You have an intrafollicular expansion of small lymphocytes. And this is where you could potentially get into the differential of a follicular lymphoma versus marginal zone. And some of these secondary markers like IRTA1 and MNDA may be helpful. You can also see kind of a different pattern. You can have marginal zone involving a lymph node with extensive amyloid deposition. This is an example of that here. We had more extensive amyloid that's being partially attacked by some giant cells that are present. So splenic marginal zone, also not very common, but very distinctive. Usually bone marrow involvement. They have a modest lymphocytosis. And what we have are these things called villus lymphocytes that kind of have little projections on them, little polarized projections. And if you are fortunate enough to get a splenectomy, you see this characteristic white pulp pattern with kind of a biphasic central zone of small lymphocytes and a peripheral zone of larger cells with pale cytoplasm. These behave typically indolently. A subset will show CD5, which has been found in some studies to have an increased lymphocytosis as well as increased bone marrow involvement. So that may be useful to look at from a clinical standpoint. Somewhat importantly, a rare subset of marginal zones are EBV-associated. This has been reported both in nodal as well as extranodal marginal zones, and they behave indolently, unlike other post-transplant lymphoproliferative disorders, which that are monomorphic that tend to be aggressive. These are fairly indolent, similar to any other marginal zone. The importance in recognizing that comes from the fact that many of these patients are post-transplant. They may be elderly on iatrogenic immune suppression. That lymphoma may actually respond to restoration of immune function. And so it's important to recognize for that reason, rather than the patient necessarily needing to undergo therapy for the lymphoma itself. It may resolve with eliminating immunosuppressive medication. All right, so lymphoplasmacytic lymphoma, many overlapping features: generalized lymphadenopathy, splenomegaly. Patients often have fatigue due to anemia. These patients also have an IgM Paraprotein, again, that can also be seen in marginal zone. But one thing that's very helpful is they often have this MYD88 L265P mutation around 95% of cases, and that can help the more diffuse interfollicular proliferation of small lymphocytes and these plasmacytoid cells, as well as potentially an increase in mast cells, particularly in the bone marrow. Example of LPL and proliferation of these B cells. Now, it's not required for the diagnosis to look for that MYD88 L265P mutation, and a subset of cases are negative for it and show a very similar morphology. And right now they're just grouped into the same category. But there has been some discussion with the possible revisions of the WHO in specifically recognizing these because most patients with lymphoplasmacytic lymphoma will respond really well to Bruton tyrosine kinase inhibitors, such as ibrutinib, because the MYD88 is upstream of this kinase, and they'll actually, so that'll just halt the signaling right here. But patients who are negative or wild type for that MYD88 mutation often have mutations downstream of that tyrosine kinase inhibitor, so they may not respond as well to ibrutinib. So it could be helpful, certainly from a clinical standpoint, to know that. So getting close to the end here, hairy cell leukemia, one of the real classic hematopathology entities. It's relatively rare, but you do see it around 2% of lymphoid leukemias. Typically involves blood, bone marrow, and spleen, very rare in the lymph nodes. Patients will present classically with pancytopenia and monocytopenia. Here's one of the peripheral blood smears. You can see there's very few white cells here. And it will involve the spleen, red pulp with an atrophic white pulp. And a classic example of one of the cells is here. Usually they don't like to let themselves be photographed so well, but this is a nice example of one showing kind of an intermediate sized lymphoid cell, kind of a round nucleus, moderate to abundant pale cytoplasm with these very fine cytoplasmic or hair projections. And nearly all of these cases have a BRAF V600 mutation, V600E mutation, which obviously can be seen in a range of entities, including melanoma, but within our lymphoid world is relatively specific to this entity. And they have a very characteristic flow cytometric findings, as I mentioned, as well as immunohistochemical findings. And there is some variation. Some cases will express CD10, rarely they have CD5, but for the most part, the phenotype is very well preserved with CD103, CD25, CD123, CD11C, bright CD20, and so you can nail down this diagnosis very well. In terms of tissue, annexin A1 is very powerful differentiating between B-cell lymphomas, very specific, but it will be expressed in other cell types, so not the best for like looking at residual disease subsequently. And this is just a classic example of involving the bone marrow. It does induce fibrosis, resulting in a dry tap in most cases. And then you've got expression here shown of DBA44 and CD123. All right, hairy cell leukemia variant can create confusion, especially if you only run a limited marker set, because they can show overlapping morphologic features with some projections, cytoplasmic projections, and expression of CD103, CD11C, bright 20 and light chain. However, you typically see more of a leukocytosis, and you also can still see monocytes. And in this case, as you can see here, you still got a pretty good aspirate. So that should raise a red flag. Maybe this isn't hairy cell. Maybe we need to look a little bit deeper. And these guys will be negative for BRAF mutations, and then they're going to have some aberrancy in the immunophenotype as compared to hairy cell. Either they're going to have 25 or they won't have 123, something like that, usually negative for annexin A1. And finally, splenic diffuse red pulp small B-cell lymphoma. This is a relatively distinct entity. You also kind of see these kind of leukemic circulating villous lymphocytes. You're going to have splenomegaly, and it's difficult to differentiate from a splenic marginal zone unless you have a hold of the spleen. And in the spleen, here we're seeing this diffuse involvement of the cords and sinusoids by these atypical lymphoid cells, where you're going to see abnormal follicles with that kind of biphasic pattern in splenic marginal zone. And so those two can be confusing until you see the actual splenic pathology. And so this is just a quick summary of some of the mutations and some of the key biomarkers that we see in small B-cell lymphomas, the MYD88 and lymphoplasmacytic, BRAF, and hairy cell variant, MAP2 kinase kind of downstream. We'll see marginal zone, we'll see various translocations, Notch2 translocations, Mantle, T1114, CLL, SLL, several very kind of a range of diverse mutations you'll see there, including the MYD88, but particularly looking at for aberrancies in TP53 or deletion of 17p can be helpful. And with that, I'm happy to answer any questions. Of course, don't hesitate to reach out to me on Twitter if you like. And that's my cat, Ginger. She's kind of scrutinizes everything, so I'm used to it. But that's it. Thanks.
Thank you so much, Dr. Crane, for this excellent talk. Can you hear me, Dr. Crane?
Yeah, I can. Yeah, I can't see where the questions are or anything, so I don't know.
Oh, yeah, no, I'm going to read questions that are there. So here is one question that I see online. What is a gray zone lymphoma?
Oh, gray zone. So today I only covered kind of the small B-cell lymphomas. So gray zone is more thinking of kind of in the range of a Hodgkin lymphoma, but doesn't quite necessarily fit exactly within that category, and so kind of may fit within a large B-cell versus a Hodgkin lymphoma. So I think normally when you receive a case, you don't know kind of what realm you're going to be in. Are we in a reactive? This is a Hodgkin, is it a large B, that kind of thing. So, today I just focused on kind of thinking we're in the small B cell realm, but yeah, gray zone kind of more in the large B versus Hodgkin realm, which is another challenging area and frequent area kind of for consults too in hematopathology, because the real nuisance there is that the treatments are very different between a Hodgkin and a large B cell lymphoma. So you want to make sure that you're going to put it in the right category, and nobody likes the clinicians don't like a diagnosis of gray zone lymphoma, needless to say, because it's harder to put into a specific category for treatment.
Thank you. So there is another question. So I think this is from a resident, I guess. So that can you explain how to differentiate BCL2 between a reactive lymph node and a follicular lymphoma? Because BCL2 is normally a T cell marker.
Yeah, so BCL2 is normally fairly broadly expressed in the lymph node. It should mark most of all T cells. It will also mark a variety of other cells that can be in the lymph node as well. And it will mark also a lot of small B cells. So the vast majority of small B cell lymphomas are positive for BCL2. Really, the only thing that's definitely negative are kind of the germinal centers. And so you should see those preserved germinal centers that are negative for BCL2. But if you have kind of an expanded paracortex and you see increased BCL2 there, well, that could be anything. That could be B cells, that could be T cells, it's BCL2 has its limitations, but gradations in expression level too are also helpful in terms of, for example, that very bright BCL2 expression, even though some B cells and some T cells normally express BCL2 not at that bright level. So that bright level is telling you that something's wrong. But yeah, it's a challenging, all the markers are, nothing's really on or off. It's like, it has to do with the whole pattern and comparing that with other stains. It's hard to use it just standalone.
Right, thank you. There is another question related to BCL2 is how to diagnose pediatric follicular lymphoma from reactive hyperplasia, since both are BCL2 negative.
Yeah, so that can create a challenge, especially since in the pediatric age range, you may see very, kind of florid reactive follicular hyperplasia. And I typically will stain these cases with Ki67 because you can see polarization morphologically, but it's more striking by Ki67. Also, of course, looking for clonality. If you have flow cytometry, seeing a clonal population that way, and kind of the shape and expansile nature is greater in the pediatric follicular lymphoma as compared to just to a reactive. And reactive usually kind of have more variation as well in kind of in size. There's some small follicles, some larger follicles. But fortunately, most of these nodes are maybe excisional, and then excision of the node is often therapeutic. They don't become systemic, and it's very indolent. So you haven't really caused a huge degree of harm either way, because you haven't caused the person to get a whole bunch more therapy that they didn't need. But yeah, so typically you can tell morphologically, and these cases are rare enough that people are excited to get them. If you have any concern, anyone would be happy to see it in consultation, because it's like those are interesting cases to get. They're very rare.
Thank you. So there is another question again related to BCL2. So this is about the clone that you have mentioned, that sometimes BCL2 can be negative with one clone, and then not everybody will have access to another clone. So then how one can suspect that? What is your advice on that?
Yeah, I mean, only actually since I've been at Cleveland Clinic have I had access to that secondary BCL2 clone, and it's, yeah, I think it's fun to have. It's nice to have, because you can just definitively prove to yourself that, oh, that really should be BCL2 positive. It's just it actually is mutated. But I think looking at the morphology, like if you look back to that example that I had, it looks very monotonous. Those follicles do not look normal. Then if you did Ki on that, you'd see that they're very low Ki67 proliferation rate. Oh yeah, here it is. And so you would know that these are not normal follicles. And this is also the same case where I had stained it with the kappa lambda ultra ISH, just because they're just a particularly nice example, and they're all lambda. So this is a clone, but I think you could arrive at that suspicion even from the morphology of those, and ideally, you could avoid this sort of headache if you also had flow cytometry of it as well, because okay, well, those are all CD10 positive clonal B cells. And so yeah, it's like, but I think it is kind of nice as a proof of principle that you realize that, okay, this, it's not really that this thing is showing a different mechanism than something else, that really still has that BCL2 overexpression that we believe is what's allowing those germinal center B cells to abnormally survive. And it's just that we just didn't detect it because the epitope was mutated. So I think it's more kind of potentially more intellectual, but it is, I think, seals the deal on the diagnosis, which I think is nice also, that there's not any question about it. But I don't think it's critical either with the other potential testing that you have at your hands to try.
Thank you. There is one more question here.
Okay.
What is the clue to diagnose diffuse follicular lymphoma on a true cut biopsy?
Diagnosing diffuse on a little biopsy?
Yeah.
I mean, I think you could hint at it, and certainly if you had done some additional testing on it and you knew that it had some of the characteristic genetic features of that, you could do it. But I think typically people would not do it. They'd say, because you typically wouldn't have, since it's such a small biopsy as well, you may not have like formal cytogenetics on it and NGS testing on it. So you wouldn't really know. But yeah, you could say like, you wouldn't really, because they typically would be the smaller cells, so you wouldn't think it was like a diffuse large B-cell lymphoma, but you may not necessarily feel comfortable putting it into that category just on a true cut biopsy, because you wouldn't be able to see the overall morphology and be certain whether or not you had other areas adjacent that were follicular.
Right. No, thank you so much.
But yeah, I definitely like having whole excisional nodes, but that's a good point, is that we really have to kind of use everything that we can to arrive at diagnosis when we have limited morphology.
Right. So here's one question regarding lymphoid follicle or lymphoid aggregates in colon biopsy.
Mhm.
So often that there is a, there are lymphoid aggregates or like, colonic biopsies, which raise the suspicion of lymphoma process. Like, I mean, so what is your advice for a standard panel to approach this when you have a lymphoid aggregate in a colonic biopsy and we want to rule out lymphoma?
Yeah, these are challenging because we can see we normally see reactive follicles in the colon, and so oftentimes I would just do, like maybe like a 3, 5, 20 Ki, kind of look like what is the distribution of B and T cells? Are these polarized? And if I don't see a major expansion of the B cells and they're well polarized follicles, going to definitely favor a reactive pattern. But if it's more atypical or you see a more expansive population of CD20, then I'll do a more full workup with our standard panel, looking obviously for cyclin D1, look at BCL2 and BCL6. Maybe you could hypothesize maybe this patient has a history of CLL, which could be involving, and then you could do LEF1. And molecular studies, if you still feel like you can't be sure what you're dealing with, I think can be reassuring that, okay, this is polyclonal. The other thing, you can see kind of a more mixed infiltrate, which you could think about. And then those ones I'll often stain for Epstein-Barr virus if it's more mixed. Looking at, CD30 Epstein-Barr virus, do we have a mucocutaneous ulcer situation going on? And other times, yeah, there could be some sort of infectious organism, something that's related to it. Sometimes you can identify that's resulting in a more robust inflammatory infiltrate. But these are ones that we frequently get. They're often sent in consultation, often shared between our service and the GI service, because that definitely is a common question of whether or not, some of these kind of robust or atypical looking infiltrates are actually neoplastic. And usually they're not so clear cut as the case of Mantle that I showed, but that was a nice case where you could say conclusively what you're dealing with.
Thank you, Dr. Crane. There is another question.
Oh, okay.
What is the plan of management and prognosis for all these types of small B-cell lymphomas? Are they similar?
Yeah, so they're different. So yeah, so it's like these things, there is a point to it, because we're like, oh, maybe nobody cares. At the end of the day, you're just giving everybody rituximab or something. But there is, there are an increasing number of specific targeted therapies that are used against specific pathways. For example, hairy cell leukemia has a very specific treatment. Lymphoplasmacytic lymphoma, as I mentioned, often those patients respond well to ibrutinib. But they may not respond as well if they don't have that MYD88 mutation. Also, a subset have that CXCR4 mutation, which will inhibit migration out of the bone marrow. These patients tend to have a higher bone marrow involvement, and so they may get a different type of therapy. Follicular lymphoma, a lot of those guys, you just kind of watch and wait if it's just low grade and it's not causing a problem. But if you've got like a 3B follicular, where it's basically, you still have meshworks and whatnot, but it's kind of basically like a diffuse large B-cell lymphoma. Like those guys, make it up front more aggressive between subtypes, as well as based on specific marker expression within those subtypes. It's definitely guiding both prognosis and therapy. So we call them, sometimes we call them indolent and aggressive B-cell lymphomas, or you call them small B-cell and large B-cell lymphomas. But not all of them are indolent. For example, mantle cell, there's certainly very aggressive forms of that are going to require a different therapy than, for example, leukemic non-nodal mantle that you don't do anything. So I think it keeps us busy, and it's also a constant area that is evolving to keep track of, to make sure that we are providing the most kind of useful data to our clinicians. And then also developing new biomarkers that may also be helpful to the field to know, which of these are responding to what types of therapy, or what types of therapy can we anticipate these would respond to. So yeah, and then like pediatric follicular, really no therapy, just kind of excision. So that's pretty good. Yeah, so this is a whole gamut. Yeah. But as I say, I'm a pathologist, of course, and so I'm not as well versed in the exact therapies. that would be engaged, but we do try to stay close contact with our clinicians.
Right.
Yeah.
Well, thank you again. And there is another question that can we have something which is intermediate between classic follicular lymphoma and diffuse variant of follicular lymphoma?
Yeah, oftentimes you will see kind of both follicular and diffuse areas, in which case the phenotype, I don't know, there could be more published on this, the phenotype often more resembles that of like the classic follicular lymphoma when you see both of those parts. And so oftentimes, yeah, when you do a true cut biopsy, you see that kind of just diffuse only proliferation. You might favor that it's, you don't know if it's the diffuse variant or if it's kind of like there can be kind of a mixed follicular and diffuse pattern there. Yeah, pretty much anything can happen in follicular lymphoma, basically, because it's so common and it can show a pretty wide range of morphologic features.
Right. Thank you. There is another one. This is about the role of marginal zone, the role of immunohistochemistry in the diagnosis of marginal zone lymphoma. So can you comment on that? That's the question.
Oh, okay. Yeah, I mean, there's definitely a role because oftentimes the marginal zone lymphoma, you don't have other testing. Like oftentimes we're not running flow on gastric biopsies or something like that. So you're looking at the morphology, and then typically you'd at least do a CD3, CD20, cyclin, and I would do a Ki-67 as well. And then you're going to see like, do I have an expanded population of B cells? Of course, you can also see a lot of T cells within a marginal zone lymphoma. And so you may see an expanded population of B cells with kind of residual germinal centers you can see by Ki, and then, lower Ki-67. But yeah, it's kind of both the morphologic pattern combined with the IHC pattern that you see, and can be quite useful to do kappa lambda. You don't always win, but if you get a light chain restricted plasma cell population associated with that atypical B cell population, then you can feel more confident. Other markers such as CD43, again, you don't always win. They may not be 43 positive, but if you see like the B cells are increased, you've really got convincing CD43 on them, that can help you establish that diagnosis as well. But it can be challenging. It depends how well developed it is. I mean, some of you see just like a beautiful expansion and they've got nice monocytoid features. There's lymphoepithelial lesions. You've got the associated clonal plasma cells, but not always that good.
Right. So for duodenal follicular lymphomas, so the immunostain pattern is similar to the nodal follicular lymphomas. Is that right?
For diffuse?
For duodenal follicular lymphomas,
duodenal.
It's the same.
Yeah. It's the same. Yeah, they should have a really nice classic pattern, and usually they look where they are at. Yeah. So this one, I only showed a couple stains. I showed CD10, and the BCL2 is a little bit brighter. You can see in these CD10 positive follicles here, and they will show BCL6 as well. So they usually look like a really nice follicular lymphoma. And, they have nice CD21 staining and associated with the follicles and low Ki. And they kind of distort the morphology a little bit, but they don't usually cause too much tissue destruction. But yeah, they kind of maybe people biopsy like a vague nodularity that they see in the duodenum or something. And then if you do a systemic workup, they usually don't find any lymphadenopathy or something like that. And so you kind of hate to even give them that diagnosis with them where they got lymphoma, but it's typically very indolent. But it does look like any sort of follicular lymphoma anywhere.
Right. Thank you. So just one last question.
Okay.
So in a biopsy from stomach, so when we approach a lymphoid aggregate and we want to differentiate between reactive versus marginal zone or a multiple lymphoma. So what's your approach? As far as morphology and immunostain is concerned, do we do just the regular panel for immunostain?
Well, here at the clinic, we actually have like a little small B cell panel. And so I think that's, that kind of has the range of things that you'd want to do, like CD3, CD20, cyclin D1, K67, CD21 to look at the meshworks. And then often would add a kappa lambda onto that. More recently, we have added that dual kappa lambda ultrasensitive stain, which I don't do in every case. Like this case, we really see kind of a really robust increase in lymphocytes here. This looks like a nice case of marginal zone lymphoma, but if it's more subtle, or maybe is this a question of recurrence or something like that, it can be helpful to use that dual stain where you can see the B cells and the plasma cells together, whether or not they're clonal. But I think in that setting, especially in the stomach where you shouldn't normally have a whole lot of lymphoid tissue, of course, it can be very helpful to just by morphology, obviously looking for H. pylori carefully. These things are all extremely helpful in that setting. So I usually don't go too much to town on the stains, other than and then obviously adding the 43 as well, in some cases, yeah. But I think the combination between the extent of CD20, CD79A that you have, and the morphology is the most helpful. But yeah, I think clonality is, rather than doing stains ad infinitum, maybe doing a shorter number of stains, and then, do I have a B cell clone here and there's H. pylori? It's like, okay, yeah, you need to treat the H. pylori. This could be marginal zone evolving marginal zone. Then we'll recheck it after treatment and see what the status is.
Right. Thank you so much. One last question. I
Okay.
think this is about Richter's transformation.
Mm-hmm.
But the question is marginal lymphoma with increased large cells. When do we call it Richter's transformation?
Yeah, that's a challenging area that has not been super well established. Increased large cells can be seen in marginal zone lymphoma. Maybe even up to like 50%. You can see like a true Richter transformation rarely. Like I have seen marginal zone lymphoma transfer to transition to like a Hodgkin lymphoma. Very rare cases. It does transform to diffuse large B cell lymphoma in some cases. In which case you need to see sheets of large cells, and I think that's really the only really defined line that we have. We don't have a specific number of large cells that are not in sheets, that are interspersed, that definitely push you to a higher category within marginal zone. It's you actually have to see that the sheets of large cells.
Thank you again. I think these are all the questions that I found online.
Okay, thank you for having. Thank you for all the great questions. Thank you, everyone. Yeah.
Thank you so much, Dr. Crane, for this excellent talk on the small B cell lymphomas, and which is really a challenging area. And I'm sure the audience learned a lot, and definitely. So we will be looking forward to hear more from you in your future talks, and you'd be really happy to hear that. We had so many viewers from different time zones, and I would just name a few. We had viewers from Lithuania, Sarajevo, Pakistan, Bangladesh, Tanzania, Italy, Cambodia, Mexico, Vietnam, Egypt, Thailand, and there were many who joined from India and US as well. And thank you again so much, and thanks to our viewers for all your encouragement. So now our next lecture will be coming up on this July 27th. So that is a talk on GYN pathology, and the topic is pathology of the fallopian tube, which will be delivered by Dr. David Colin, who is a associate pathologist at Brigham and Women's Hospital in Boston. So hope to see you then. So that will be again on July 27th at 9 a.m. Eastern time. And thank you all for your support. And thank you, Dr. Crane, once again. Thanks a lot.
Thank you. Thank you so much for having me.
Thank you.
Bye.